Of all the changes that accompany the menopausal transition, none are more famous or more universally disruptive than vasomotor symptoms. VMS, the medical term for hot flashes and night sweats. For the millions of women who experience them, these are not minor inconveniences. They are powerful physiological events that can derail a business meeting with a sudden, drenching sweat, shatter a restful night into a frustrating cycle of waking and chilling, and profoundly impact one's sense of well-being and control. Affecting up to 80% of women, these symptoms are a hallmark of the hormonal shifts of perimenopause and menopause, but you do not have to simply suffer through them. Understanding what is happening in your body is the first step toward finding the relief you deserve and navigating this transition with confidence. Show your support for women's health with a quick like, share, and subscribe. The brain's faulty thermostat, understanding the hypothalamus. The root cause of hot flashes and night sweats lies deep within your brain in a sophisticated control center called the hypothalamus. Located at the base of the brain, this homeostatic command center acts as your body's master thermostat, working tirelessly to keep your core temperature within a very narrow, stable range known as the thermoneutral zone. This regulatory function is heavily influenced by a delicate balance of hormones and neurotransmitters, and the female hormone estrogen plays a crucial role in maintaining this stability. Estrogen helps to keep the thermoregulatory system running smoothly and with a wide margin of tolerance, promoting heat dissipation responses to maintain a lower core body temperature. During perimenopause and menopause, your ovarian production of estrogen begins to fluctuate wildly and ultimately declines to a very low, stable level. This withdrawal of estrogen disrupts the fine-tuned chemical balance within the hypothalamus, making it overly sensitive and prone to error. Your internal thermostat becomes faulty and develops a much narrower zone of thermoneutrality, meaning the range of temperatures it considers normal becomes very small. Things that would not have bothered you before, like a slight increase in room temperature, a sip of warm coffee, or a moment of stress, can now push your body outside this narrow comfort zone, tricking your brain into thinking you are severely overheating. A major breakthrough in understanding this process came with the identification of a specific group of neurons in the hypothalamus, known as KNDY neurons, for kisspeptin, neurokinin B, and dynorphin. These neurons are powerfully suppressed by estrogen. In its absence, they become hyperactive and enlarged, a state now understood to be the central trigger for the entire hot flash cascade. The hot flash cascade, a physiological miscommunication, responds to this false alarm from hyperactive KNDY neurons. Your hypothalamus triggers a powerful and aggressive cooling cascade. The key signaling molecule in this process is neurokinin B, NKB, a peptide released by the KNDY neurons. NKB travels to the brain's thermoregulatory center and binds to its receptor, which acts as a false overheating signal. This has been confirmed in human studies where an infusion of NKB reliably induced hot flash symptoms. This false alarm sends urgent signals through the sympathetic nervous system, your fight or flight response, to rapidly dilate the blood vessels near your skin's surface, a process called vasodilation. This is the vaso part of vasomotor symptoms. This causes the intense spreading flush of heat you feel, particularly in your chest, neck, and face, as your body shunts blood to the skin to release the non-existent heat. Your heart rate may increase and you might feel palpitations as your heart works harder to facilitate this process. Simultaneously, your sweat glands are activated to release sweat, your body's most effective cooling mechanism. The entire event can last anywhere from 30 seconds to several minutes. After this intense heat dissipates, the aggressive cooling response often overshoots its mark, causing your core body temperature to drop slightly below the new narrowed set point. This triggers the second phase of the experience, the post-flash chill, where you may begin to shiver as your body attempts to generate heat and bring your temperature back up. This entire process is a physiological miscommunication, further destabilized by the loss of estrogen's steadying influence on other key neurotransmitters like serotonin and norepinephrine, which are also essential for temperature control. Identifying personal triggers, the first line of defense. Managing these vasomotor symptoms often begins with identifying and mitigating your personal triggers. While the underlying cause is hormonal, certain external factors and lifestyle choices can provoke a hot flash by nudging your body temperature just enough to cross the threshold of your narrowed comfort zone. Keeping a simple symptom diary for a couple of weeks can be incredibly illuminating in pinpointing your specific vulnerabilities. Common triggers include hot beverages like coffee and tea, spicy foods containing capsaicin, alcohol, particularly red wine, which can act as a vasodilator, and high sugar foods that can cause fluctuations in blood glucose. Stress is another major culprit. The release of stress hormones like cortisol and adrenaline during a moment of anxiety can be enough to set off your hypersensitive thermostat. Warm environments, such as a stuffy room, a hot car, or overly warm bedding, can also initiate an episode. The first line of defense is a practical lifestyle-based approach. Dress in layers of breathable fabrics like cotton or linen, so you can easily remove clothing when you feel a flash beginning. Keep your bedroom cool at night, ideally between 60 and 67 degrees Fahrenheit, 15 to 19 degrees C, and consider investing in cooling pillows, a mattress topper made of gel-infused foam, or moisture-wicking sheets and pajamas. Carrying a portable handheld fan or a cooling facial spray can be a lifesaver during the day. Beyond avoiding triggers, proactive lifestyle strategies can significantly improve your body's resilience to vasomotor symptoms. These approaches focus on enhancing your body's natural thermoregulatory control, managing stress, and promoting overall well-being. Mind-body practices are surprisingly effective. One of the most accessible is paced respiration, a form of slow, deep, diaphragmatic breathing. This technique involves inhaling slowly through your nose for a count of 5 to 7 seconds, and then exhaling slowly through your mouth for the same count. Studies have shown that practicing this for just 15 minutes, twice a day, can significantly reduce the frequency and severity of hot flashes by calming the sympathetic nervous system, which is responsible for the fight or flight reaction that accompanies a flash. Regular physical activity is another powerful, evidence-based tool. Exercise training appears to directly improve the body's thermoregulatory control system by lowering basal core body temperature and enhancing the efficiency of heat dissipation mechanisms like sweating and cutaneous vasodilation. In one compelling study, previously sedentary menopausal women who began a program of moderate intensity exercise, jogging or cycling 4 to 5 times per week, experienced a remarkable 60% reduction in the frequency of their hot flashes. The goal is to aim for at least 50 minutes of moderate intensity aerobic activity, like brisk walking, combined with 2 sessions of strength training per week. Strength training is particularly important as it helps build and preserve muscle mass, which in turn boosts metabolism and strengthens bones, counteracting the increased risk of osteoporosis after menopause. Dietary choices also play a role. While there is limited evidence for specific foods, adopting a healthy dietary pattern can be beneficial. The Mediterranean diet, which emphasizes fresh vegetables, fruits, whole grains, legumes, nuts, and olive oil, is an excellent model. This diet is known for its anti-inflammatory properties, which may help stabilize the thermoregulatory system. A recent cross-sectional study found that women with the highest adherence to a modified Mediterranean diet had 80% lower odds of experiencing moderate to severe VMS compared to those with the lowest adherence. Maintaining a healthy body weight is also beneficial, as excess body fat can act as insulation and is associated with more severe vasomotor symptoms. Finally, prioritizing sleep hygiene is crucial, especially if night sweats are disrupted. This includes maintaining a consistent sleep schedule, creating a cool, dark, and quiet bedroom environment, and avoiding blue light from screens for at least an hour before bed. Medical treatments. Menopausal hormone therapy, MH. When lifestyle modifications are not enough to provide adequate relief from moderate to severe symptoms, it is time to discuss medical treatments with your doctor. The most effective treatment available for hot flashes and night sweats is menopausal hormone therapy, MHT, often called HRT. By replacing the estrogen your body is no longer making, hormone therapy directly addresses the root cause of the problem. It works by restabilizing the hypothalamus, widening its zone of tolerance, and effectively stopping the false overheating alarms. For women who still have a uterus, estrogen is given along with a progestogen, like micronized progesterone or a synthetic progestin, to protect the uterine lining from precancerous changes. This is known as estrogen-progestin therapy, EPT. Women who have had a hysterectomy can take estrogen-only therapy, ET. The conversation around MHT was profoundly shaped by the Women's Health Initiative (WHI) trials in the early 2000s. These large-scale studies were initially stopped early due to findings of increased risk for breast cancer in the EPT arm and stroke. This generated widespread alarm and a sharp decline in MHT use. However, subsequent more detailed analyses of the WHI data revealed a critical nuance. The average age of participants was 63, much older than the typical woman starting MHT for symptoms. This led to the timing hypothesis, which is now central to modern menopause care. This hypothesis posits that the benefit-risk profile of MHT is most favorable when initiated close to menopause. For most healthy, symptomatic women who are under the age of 60 or within 10 years of their final menstrual period, the benefits of MHT are now understood to outweigh the potential risks. In this younger population, MHT not only provides superior symptom relief, but also protects against bone loss and has been associated with a neutral or even favorable effect on all-cause mortality. Conversely, initiating MHT more than 10 years from menopause onset or after age 60 is associated with greater risks of coronary heart disease, stroke, and venous thromboembolism (VTE). Today, the guiding principle of MHT is personalization and shared decision-making. Treatment should be individualized, using the lowest effective dose for the duration necessary to meet treatment goals, with periodic re-evaluation. A variety of formulations are available, including oral pills, transdermal patches, and topical gels or sprays. Transdermal methods, like patches and gels, deliver estrogen directly into the bloodstream, bypassing the liver. This route may be associated with a lower risk of blood clots, VTE, and stroke compared to oral pills, making it a preferred option for many. While MHT is highly effective, it is not suitable for everyone. Women with a personal history of breast or uterine cancer, undiagnosed vaginal bleeding, a history of blood clots or stroke, or active liver disease are generally not candidates for systemic MHT. Effective non-hormonal prescription options. Hormone therapy is not suitable or desired by every woman. Fortunately, there are several effective non-hormonal prescription medications that can provide significant relief. The most well-studied of these are certain types of antidepressants, particularly low-dose selective serotonin reuptake inhibitors, SSRIs, and serotonin norepinephrine reuptake inhibitors, SNR. Medications like paroxetine, venlafaxine, and escitalopram have been shown to reduce the severity and frequency of hot flashes by 40 to 65% by helping to stabilize the serotonin and norepinephrine systems in the brain's temperature control center. A low dose of paroxetine, 7.5 mg, is the only non-hormonal drug specifically FDA approved for this purpose. Another medication called gabapentin, which is primarily used for nerve pain and seizures, has also been found to be effective, especially for night sweats. Clonidine, a blood pressure medication, can also provide some relief. A groundbreaking newer non-hormonal option called fazolinetant works by directly blocking the activity of the neurokinin B receptor on the KNDY neurons, the very neurons that trigger the hot flash cascade. This targeted approach is highly effective, reducing VMS frequency and severity by over 50%, and represents a new era in non-hormonal treatment. Many women are also interested in supplements and alternative therapies. The evidence for many of these is mixed, and it is important to discuss them with your doctor. Soy isoflavones, found in soy products and supplements, contain plant-based estrogens that may provide mild relief for some women. However, a large meta-analysis found their effect to be slight and slow, providing only a modest 25% reduction in hot flashes after subtracting the placebo effect, and taking over 3 months to reach half of their maximal effect. Black Cohosh is another popular herbal supplement, but systematic reviews of multiple studies have yielded conflicting results, finding insufficient evidence to support its use over a placebo. Cognitive behavioral therapy (CBT), a type of talk therapy, has been shown in multiple clinical trials to be an effective non-pharmacological approach. It does not reduce the number of hot flashes but helps women manage the distress associated with them by changing their cognitive and behavioral responses to the physical sensations, leading to significant improvements in quality of life. The North American Menopause Society, NAMS, is an excellent resource for evidence-based information on all treatment options. Their position statements consistently affirm that menopausal hormone therapy is the most effective treatment for vasomotor symptoms, but also support the use of non-hormonal therapies for appropriate candidates. Ultimately, the choice of treatment is a personal one, made in partnership with your doctor. If you feel your concerns are being dismissed, seek out a provider who is a NAMS certified menopause practitioner, NCMP, as they have specialized training in this area. The key message from gynecologists and menopause specialists is that suffering is optional. Hot flashes and night sweats are treatable medical symptoms. By having an open conversation with your provider, you can explore the full range of options and create a plan that restores your comfort, improves your sleep, and allows you to thrive during this new chapter of life.